our journal club. The study we're discussing today is called Rapid Antigen Testing, also known as RAT, for the management of Group A streptococcal pharyngitis in community pharmacies. It is a prospective, multi-center, non-randomized feasibility study conducted in community pharmacies in Lorraine, France.
Yeah, and it looks like the clinical question they're really addressing here is, does access to this rapid antigen testing, lead to better treatment and more effective treatment for patients, when it's offered by pharmacists?
Yeah, I think so. It has already been established that RAT testing can reduce the inappropriate use of antibiotics in the treatment of acute sore throat, such that the use of RAT testing is actually outlined in the 2012 European guidelines on the matter.
And the paper, which is less than a year old, references previous work such as random control trials on the topic, while they focus on understanding the qualitative aspects of it.
Yeah, it used qualitative surveys to look at the study outcomes after patients were selected in community pharmacies.
So just to elaborate on that a little more, the study involved voluntary enrollment of adults presenting to a participating pharmacy in the 6-month test period with a sore throat. These patients were offered a pharmacist-led assessment that followed the 2012 guidelines for the management of acute sore throat by the ESCMID Sore Throat Guideline Group.
All patients involved were handed educational pamphlets about what was kind of going on, and they were given testing to assess appropriateness, which was the center score. So if they scored over 2 and they hadn't seen a doctor, they were then able to receive this RAT testing. So I think the paper says something here about 566 people enrolled in the initial project. 367 were offered the RAT testing, and of that 367, 28 did refuse the RAT testing.
Yeah, but only 140 completed the follow-up, even though their anonymity was ensured.
Yeah, and the stats were really only done on the people who did the follow-up, right? The comparator population were the people who presented to the pharmacies but didn't get the RAT testing. And when looking at selection bias, the group compared the intervention group to people in Lorraine based on demographics.
The study went really into depth on how it assessed and accounted for the selection bias. I really like that.
Okay, but before we get into that, I think we should just talk about the outcomes and the results. So from what I understand, the main outcomes of the study were assessing the feasibility, the benefit and the acceptance of community pharmacist-led RAT testing based on interventions in adults with sore throats presenting in Lorraine.
That's what I think. To assess benefit, they looked at who ended up going to the doctor for antibiotics after RAT testing, and 10 of the 10 that were positive on the RAT test saw the doctor for antibiotics, and of those with negative RAT tests, only 4 out of 114 ended up seeing the doctor anyway. That corresponds to the random control trial studies that show that there is a benefit and reduction in antibiotic use.
And to assess the feasibility and acceptance by pharmacists, they asked if the training they received was adequate, if they were happy with the process, and if pharmacists would do it again in the future. And from what I understand, over 90% of pharmacists who did follow up said they were happy with the process, and they found the testing to be good, and they would do it all again.
That makes sense. I imagine I would like offering a test like that. It'd be good for business, and it's less involved than a flu shot.
All patients were happy with pretty much all aspects of the testing itself. And this might sound a little surprising, but when you think about it, we could kind of guess that most people that followed up were probably people that were more satisfied with the results they did get from this testing.
Okay, so the study found what it aimed to do, but we cannot really say it's a good study now, can we? A major weakness was the massive loss to follow-up. Only 140 out of 566 people initially enrolled completed the follow-up survey. This impacts validity. So was the method of follow-up simply inconvenient for patients? I'm not sure what's going on.
Maybe, or like Aaron said, people just forgot if it didn't help much.
Another weakness was the study design. It wasn't an RCT, although it followed some, and it wasn't blinded, but this kind of makes sense. And there was some pretty notable selection bias.
Yeah, but they did do their best to address the selection bias, both using statistics and discussion. And I felt their approach was adequate, and it added a lot to the validity of their findings.
Yeah, and maybe this just reflects the real life situation, Lorraine.
So this study was small and had some issues with bias, dropout, and therefore its validity was affected. But it appears to be a study that's tying up the loose ends of what seems to be the end of research phase of implementing an idea like this in practice. In the grand scheme of things, other work has shown that RAT is valuable, and doing small-scale surveys on acceptance does make sense.
That's a great point. The cultural and socioeconomic profile of each population is different in meaningful ways, so perhaps it is best to use smaller, qualitative and non-blinded studies to assess feasibility and acceptance of interventions such as these pharmacist-led RAT testing.
Also, in the age of antimicrobial stewardship, adding more gatekeepers to antibiotic dispensing and prescribing is in everyone's best interest.
So the bottom line is that basically the paper is piggybacking off a lot of high validity random control trials, but it's just a small trial that is looking at the feelings of people implementing this in a real world setting. However, its issues with validity, dropout, and bias do discredit the almost unbelievably positive results that it did find.
Yeah. So all in all, it's an interesting read, and I would be curious about the results if the same trial was done here.